Thank you. I'm going to try not to take 20 minutes because I actually need your help. So I am an associate professor in the Department of Obstetrics and Gynecology at McMaster University. And I study traveling for birth for Indigenous peoples. And I work with Rebecca to map how people travel for comprehensive gender inclusive sexual and reproductive health and care in Ontario. The name of our research lab is Returning Care and Health Home and Indigenous Health Commitment. Right now we're developing. Keep going. Right now we're developing an atlas for Canada, for Ontario, with the help of Rebecca and Peter. The work that I do is exceedingly important to me, and I'm fidgeting right now because I'm really trying very hard not to cry, because our name is exceedingly purposeful. And it's not just about Indigenous people having health and care in their communities and homes and not having to travel away for 2 or 3 months at a time, but the word home is meant to acknowledge. You have to talk to me. It's meant, I'll just pretend I'm talking to Rebecca. It's meant to acknowledge people who are trans, who find home in their gender and their expression of gender. And there's a lot of a lot of transphobia in Indigenous communities. And I refuse to have that part of my life and my research. This is a very intentional name. And this is our branding, because we're also intentionally not having boring branding. And if you go to the first slide, this particular one is just like iconic to me. So for those of you who know, and I really hope many of you know, but if you don't, that's okay too. So slide 3. So Indigenous people in Canada are constitutionally defined. So the Canadian Constitution was patriated from here in 1982, but originally developed in 1867. And we have 3 constitutionally defined people, and that is, yes, on this slide. So in the Constitution, it says Indians, Métis, and Inuit. Indians are now called First Nations as a result of the Red Paper in 1969. And then the National Indian Brotherhood changed it to First Nations. That's the history. So this is a map of all the First Nations communities in Canada. And the triangles are their tribal councils. There are at least 50 different nations, and I mean capital N, in Canada, and that's not including Métis or Inuit. This map is really important for health because it also describes some of the funding arrangements between the government of Canada and these particular political bodies. So look at how complicated. Each one of these may have their own healthcare system that is defined through some type of contribution agreement. So it's quite complicated. So Inuit, as you probably know, that showed up poorly, but it showed up, have 4 comprehensive land agreements, which is a type of modern treaty. So in Canada, we have historic treaties, numbered treaties, and comprehensive land agreements, or modern treaties. And so the Inuit have land claims through a comprehensive land agreement, which includes a political structure related to resources and resource allocations and funding it from various government entities outside of their comprehensive land agreements. We have 4 of them in Canada. And please feel free to jump in anytime. There are Métis settlements. I'm not going to go too much in this. I find it very difficult and challenging to do research on Métis health, simply because in Canada we're having like, oh, you just have to Google it. Yes, how do we define Métis people outside of just the constitutionally protected word within the Constitution? As a little FYI, the person, Paul Chartrand, who had that word inserted into the Constitution was the elder on my PhD committee. So this is a very small world that we live in Canada. We almost all know each other, despite the huge geography. So this is an example, and Rebecca added this slide, which I really appreciate. Would you like to
Yeah, sure.
offer a few words?
So as we were talking about coming here, I wanted to contextualize this a little bit as to how does this fit in with Arctic data? Like if we're talking about First Nations, Métis and Inuit, what is the role of Arctic data? It's like, at what point is this Arctic? So I live outside of Ottawa. Carleton is located in Ottawa, and so many people have to fly from Iqaluit to Ottawa to receive treatment that there is actually an industry geared towards hospitality and care for those people. Like that is the extent to which people are flown into Ottawa from Iqaluit in particular. And it's because they cannot receive the type of care that they need in the Arctic in Iqaluit. So when we're mapping these issues, the idea of Arctic becomes kind of transportable because we're talking about people who are Arctic peoples that cannot receive what they need within their own communities. It kind of changes the idea of data for us because then you're thinking, what part of that actually is Arctic? Are we talking about the people? Are we talking about the place? Or are we talking about this entire process having to do with their care? And for me, it's more the process than anything else. One of the aspects that we're doing, are you talking about the cost analysis module?
No, but you could.
Okay. One of the things that we're working on is a cost analysis module that examines this and asks, is it more cost effective for us to be doing this or for them to be receiving the care in their own communities? So that in particular is a big chunk of where we in particular could use support resources, things like that. Not so much from the mapping perspective, but more from the Arctic resources perspective.
Yeah, so interesting. So interesting. This excites me. Now I'm excited. So just talking about the epistemological foundations of desire-based research. And I provided these definitions because I heard someone talk about ontology yesterday, but I don't know that we're using that word in the same way. So ontology is what you believe is real and the study of existence. Epistemology, how you think about this reality. Your axiology is your set of moral or ethics, your morals. And methodology is your philosophical discussion about methods. I also consider methodology 100% different than methods, and many people blend those two ideas together, which in my training doesn't make sense, but I go with it. I would have to say that Indigenous people foundationally, at least in the Americas, understand all of these words all the time. They might not know what these words in English mean, but their thoughtfulness in their life and is constantly framed around these ideas that I'm presenting here with my fingers, but it's up on the board. And that is something I think is really important to understand, is that Indigenous people have knowledge, carry knowledge, and can be knowledgeable. So one of the things I used to do in my research was I proved something was real. So one of my activities as my PhD was I studied something called evacuation policy. And what it is everyone from the north, basically anyone outside of Vancouver, Edmonton, Calgary, Saskatoon, Regina, do you get the point here? Almost all, and then Toronto, Ottawa, Kingston, London, Montreal, everyone gets flown south. They get flown to those areas. But somebody told me that it wasn't real, this policy. And in fact, I had the head nurse of the Ontario region for the government of Canada phone me and said, Karen, I don't want you to do this research. You're going to embarrass yourself. It's not real. So just for your benefit, you should change topics. Well, if you know me, you probably have a sense that's going to just really make me angry. So I actually wrote a policy paper with a tool to identify invisible policies. And that policy tool has been used to identify forced and coercive sterilization of Indigenous peoples in Canada, and will undoubtedly make the effects across the world. So I'm very proud of that work. Then I had to prove that the evacuation policy existed. Do you see how exhausting this is already? Yes.
One of the things that I need people to understand, and my father is a physician. He was a physician in the United States for 30 years. When I tell him what happens to my friends and my family, he does not believe that they are happening.
Yeah.
I have had instances of friends who were part of the 60 scoop forced adoption, who cannot get a hold of their medical data even when they go and ask for it. I have had instances of, we've had deaths from racism, like flat out people have been recording what is happening, and they die as a result of that racism. Every one of us knows someone who had a child taken. Every one of us knows someone. Every one of us knows someone who went to residential school. When I tell you that these things happen, it is extremely difficult to hear. It is extremely difficult to believe that they are real. They are real. They are happening. People are dying because of it every day. And this is part of that. So the data is a huge aspect of all of this work. It's literally about life or death.
Yes, it is. So I would describe that, and I prove it's real using the academic language and all the literature and all this garbage. Because people told you it was happening, and instead of believing it, you asked me to prove it. What a waste of my energy. I did it. For you, not you people here, but you, the world. And then I'd just say how it was bad and had to go into all the various conventions and commitments by Canada and perhaps the United Nations. And then I would do a policy analyst for the bureaucrats who actually do all the funding allocations, resource allocations for people's health. Then I would offer recommendations. Do you see how boring this is? I would do this over and over, and I just got bored because it's really obvious. It's routine, it's deficit-based, it's blameful, and certainly there are people to blame. Let me make that very clear. But it's hard for me to do this. There's a reason why I'm so angry when I talk about this, because otherwise I'll be in like the fetal position, bawling my eyes out. It's very personally harming to me. It just is taxing, emotionally draining, and morally injuring. Injury is actually a concept developed from soldiers who had to go against their morals of thou shalt not kill and going into war and killing people. And that huge disconnect is part of moral injury that's related to PTSD. And of course, in my research, I found extreme disrespect for Indigenous peoples, Indigenous healers, knowledge keepers, and Indigenous midwives. I forgot to mention I'm also a midwife. I'm an Anishinaabe midwife, and I also am trained in a Western model, so I'm also a registered midwife in Canada. Coercion, I found, lies, threats, stealing children. This is just what's documented. Torturing children. I can't tell you anything because Rebecca will cry. And I don't want to do that to you, but please, if you have any questions about this, I can refer you to the resource. This is all documented and some of it recorded. Not at the time, sometimes it is, but people's experiences. Definitely isolating and confining pregnant Indigenous peoples was purposeful as to civilize and assimilate us into a generic Canadian body politic. And that's actually text from one of the Indian agents who was tasked to design the Indian residential school system. So what I wanted to do was I wanted to stop doing my work because it was so awful. But I know that my work is really important, and I wanted to figure out how to shift it, change it, but still do my work. And so I thought of desire. I read this is another great work of queer theorists and queer authors, is they talk about desire. And of course, desire is a very weird topic because in English, it's almost automatically related to the erotic. And erotic in English is always sexual. But desire is something else. Desire has an intimacy, a relationship with it that you can of course desire an intimate sexual relationship, but you can also desire an intimate relationship, say with your partner, or you can desire to have a really good relationship with your doctor. That is an intimacy on a different level. And it's the desire that I want to examine. So I'm actually the first English speaker of my family. My as a first language because of how isolated we are. Like my mother was born on the land and Anishinaabe is her first language. So I'm the first generation to be born off the land and have English as my first language. So I'm always like, what is English? And I think that there's an intimacy of research that I thrive on. Like it's just such a wonderful part of my life that even it's so fulfilling. And what if I actually then centered all of my research around the concept and the intimacy of desire? And that's what I've done. And that then addresses those issues that I had with a research that's deficit-based. Did I miss a slide? Oh, did I miss, yes. Did I miss a slide, Rebecca?
You're on the flower, the next one.
Oh, I am, okay, thank you. It's because I know that when I ask people what they desire, they'll still tell me bad stuff. They'll still tell me, you know, a typical one. I went to the doctor, my ankle hurts. So if your ankle hurts and you're a woman, what happens? What does the doctor say to you? What?
Lose weight.
Lose weight. That is 100% what happens. And I know people are gonna tell me that, but if I ask them, what do you wish, what do you desire had happened in that dialogue with your physician? There's another
Higher the
full-
dialogue.
Yeah, so I told this story to a white man of some academic privilege, quite high, about desire. And I asked him what he desired what did he want for supper? And he said, I'm gonna have chicken. They had leftovers. I said, what would you, oh no, he said pasta. That's right. He said pasta. I said, what do you desire? He said, I desire pasta. I wish I was in Italy with my wife again. And we had wine, we had pasta, we were sitting, he described the whole scene. And it was so beautiful. He described his wife, how much he loves her, the landscape, it was still pasta. And that's what happens when I switch to desire, I'm creating an intimate space of tell me more. I really do want to know what you think. And I don't know that'll work for everyone, but I feel good about my work now. And this is the Milky Way. Is there someone from New Zealand here, I thought? There was though, wasn't there?
There was, Peter's not here today.
Okay, because I went to Hobbiton and they sang a little song around us at the midnight, the late session, and we saw the Milky Way. And this sticks with me because I wonder what could be if we shifted our research into desire instead of what is and pointing out all the problems all the way. And this is what I think. I think I'm gonna approach the topic in a more thorough manner because one thing that's very easy to do is have a hate on for physicians. Very easy, especially OBs, obstetricians. But what if I understood more their pressures and how do they desire to work in a model that is actually fee for service in Canada? And how could they better serve? How come they're all located in a city that's like 4 million people? Where do they desire to work and how might then we address things, not just healthcare, but health workforce planning? How is obviously the geography of where service is provided is very important to me. I'm gonna read, can you go to this slide? The conundrums. This is supposed to be Arctic cotton, by the way. And I'm gonna read to you a quote and this is how I'll end. Because Sean Wilson, who's actually located now in Wollongong, Australia, which I know you know where, because I know you're from Australia now. And he's actually Cree from the prairies in Canada. And so when I read this quote and it says country, it doesn't mean the geopolitical, like the land is my home. Because this was written with colleagues in Australia. So preparing ourselves for the ceremony of research is akin to preparing ourselves to be in good relationship with knowledge and with whoever else participates in the research, including other human beings, more than human beings, and country. To prepare, we need to cultivate the values that make for good relationships, including respect, receptivity, generosity, humility, compassion, and care. We also need our skills of attention, deep listening, and service. I love that quote. Fills me with hope and desire. But one of the things that and Rebecca and the RCHH with Peter, how do we map desire? Because it's very, very important to understand where people desire their healthcare so that we can actually move people into those spaces. For how long, I don't know. Maybe they do month on, month off. I don't know. But I have no idea what to do. And if you ever think of it, something, anything, please, can you let one of us know?
Yes, we can provide you with some time for questions.
Now they can continue to talk.
Alex,
So do you think in your, let's say it's a change of methodology that you may have gone through, do you think you can compare the data and the information that you may have collected before through to things that you now receive from people with a new mindset of how you're getting that information or data or whatever you want to call it from them?
This is an excellent question because I'm thinking that you're talking about the FAIR principles. Like, is it like and so one of the things that is important in research in Canada is following various Indigenous design ethical protocols. And part of it is that if I collect research for this project over here, I cannot use that data for this project. So that sort of settles that question. I just can't do it because that's not it's unethical to use this data for this project unless I specifically said I would. And so then we come down to the design question of the research is shifting my, basically my entire framework of my point of entry into the research. Will that change the findings? It will have enriched the findings because I've not done a good enough job at the beginning. Where do you want to give birth? I could ask all of you this, except for people who don't want to have children. There's a growing number, I think they're called the millennial extension. What is it called? Extinction, that's what they're called. Extinction millennials, they don't want to have kids. So, but usually, everyone has an idea, but I think it's just a reflection of my engagement with research as well as Indigenous ways of knowing. Even though I'm Indigenous, I still need to keep learning. And I think that, and I don't want to use the progression because that's a very Western concept associated with development, which is about colonialism, but it's to further my own understandings of my knowledge and my understanding of how to better engage as someone who sort of walks this little tightrope of being Indigenous and working in an extremely colonial institution. Gosh, I used to work at Queen's University a few months ago. How more colonial in Canada can you get? And it's just how to better walk. And so I think your question is very helpful and one that I'll reflect on, but I'm sorry I don't have a definitive answer at this moment. I think it will be ongoing. I appreciate you. Thank you.
yes, at the back.
Shannon?
Yes. So in the Western Arctic, a lot of communities in the north are evacuated to Edmonton. That's the main center if there's a medical issue. And my niece actually recently started working in Yellowknife. She is a chiropractor and she works in Calgary one week and then goes up to Yellowknife for the next week. And she was absolutely shocked, I was not, at how many people she sees, new patients in a day, not necessarily for chiropractic reasons, but because she's the closest thing to that they can go and see. And I was wondering if your research tracks any of that with paraprofessionals or if that's an extension.
So right now we're working on the Ontario map because I do have 3 years of funding through CHR, through a project grant.
But even paraprofessionals in that area.
So we haven't done the interviews yet because we're still establishing the map, but then we're gonna do a Canada-wide one and I'm hoping to engage after that with Canada, United States, Australia, and New Zealand. And then, sorry.
Oh, wow.
Okay, so this is a really good question. I think like focus and scope are always on the radar. And that was actually one of the very early issues. So it is possible to download from Ontario GeoHub all of the Ministry of Health data. And in doing so, I ended up with 11,000 odd records, which I'm still, sorting isn't quite the right word. The problem with the data is that it is not very well defined in terms of categorization. So a lot of what I've done over the past however many months has been trying to figure out how to categorize that data. I think we're slowly getting there, but that's part of the question is who are we including and who are we excluding and why? And is this, the way that the Nunali platform works is that it's an iterative process, right? So I go in, I throw some stuff in QGIS, we call it a layer, we export it, we get it into Nunali. But then there's this whole series of, is this actually what we want? Are we being shown specific spatial patterns? Do we want to kind of reevaluate and tweak it at all? So I think we have we have kind of this minimum of this, we know that this is useful. We think this may be useful and this is not useful. And right now the strategy, and we just came up with this last week, is keep it off unless someone specifically mentions it in the interview, because then we know this actually is significant. And I can't say to what extent that's gonna work. But the rest of that is, I anticipate this project continuing for quite a while, and that eventually I think that those things will be on there, just I can't say in what form.
Thank you, that's very interesting.
Thank you very much. If you have further questions, you can ask them during the break. Thank you very much.